Hello and welcome to week 10. This week we'll be talking about a few things including coronal polishing, fluoride applications, and placing sealants. Starting with coronal polishing. So coronal polishing is a procedure that makes the tooth free of plaque and extrinsic staining. There is a difference between coronal polishing and what we call a prophylaxis or a prophy. The coronal polishing is strictly limited to the clinical crowns of the teeth, so above the gum tissues, and will not remove any calculus. A prophylaxis, on the other hand, a prophy, will go below the gum line. So what we do is a little bit different than what hygienists do for a normal prophy appointment. And coronal polishing can remove plaque stains or be done prior to placing sealants just to clean any debris off of the tooth before those sealants are placed. So what are the benefits of coronal polishing? Number one, it can help prepare the teeth prior to the placement of sealants or even orthodontic brackets because it's removing any debris, plaque, food left over from lunch before those sealants or brackets get placed. It also allows a smooth surface so the patient is able to keep it clean a little better. Plaque is going to attract to rough surfaces, so by keeping it smooth, it's going to stay cleaner easier. Fluoride also is better accepted into the enamel when it is clean. And then patients also appreciate that smooth and clean appearance that they get after a coronal polishing. Next, we'll discuss indications and contraindications for coronal polishing. Indications include before placement of sealants, before placement of a dental dam, before cementation of orthodontic bands, before application of acid etching solution on enamel, and before the cementation of crowns and bridges. Again, we just want a very clean, smooth surface. That way these agents are able to better bond to the tooth structure itself. Contraindications include when no staining is present, patients who are at high risk for dental caries since there is a small amount of enamel that is removed during the procedure. Sensitive teeth because, again, all these abrasive agents in the polishing paste itself can kind of scratch that enamel surface and remove small parts of it, which will in turn make the teeth a little bit more sensitive. And then also newly erupted teeth because mineralization may be incomplete at that point if they are just newly erupted. Precautions for coronal polishing. So the need for coronal polishing must first be determined and authorized by the dentist. So they're going to be the ones telling us we're going to do a coronal polishing. Things to take into consideration: the patient's health history, any patient's allergies, so if they're allergic to anything in the polishing paste or even the rubber itself that's used on the cup. Educating the patient both before the polishing and after the polishing. Avoid over polishing because, again, it can wear down the enamel slightly. Both the operator, us, and the patient should be wearing some kind of eye protection, safety glasses. Be careful around the gingiva so that you're not traumatizing it or causing any lacerations in it. Avoid using abrasives around implants because it can scratch the implants, which allows plaque to become attached to the implant, and it could lead to failure ultimately. And use non-fluoridated pumice prior to sealant placement. Sometimes that fluoride in the prophy paste can affect how the bonding agent adheres to the tooth structure. It can lead to improper bonding. Possible damaging effects. So on the tooth surfaces, we just mentioned this a few slides back, but newly erupted teeth are not completely mineralized, and over polishing them could remove a small amount of that surface enamel there. So we just want to be very careful polishing newly erupted teeth. Avoid polishing cementum in areas of recession because it's softer and therefore can be removed easier. So those abrasive components of the polishing paste will wear away the cementum much faster than the dentin or even, of course, the enamel. And then avoid polishing areas of demineralization because of the possibility of loss of surface enamel. Gingival tissues. So gingival tissues could be damaged if the cup is run at a high rate of speed or just applied for too long. And also the fast rotation of the cup may force particles from the polishing agent into the sulcus around the tooth, and that can lead to irritation, inflammation, soreness, bleeding gums, all things that we don't want. Restorations. Abrasive paste can leave scratches or rough surfaces on gold, composite restorations, acrylic veneers, and porcelain surfaces. So we really want to try to limit how much we're polishing those types of surfaces for restorations. or use a very low abrasive polishing paste. So types of dental stains. First we have the endogenous. Endogenous stains originate within the tooth through developmental and systemic disturbances. So they cannot be removed by polishing like extrinsic staining can. Causes can include excessive fluoride during tooth formation and any medication that's taken by your mother or as a child during tooth development. A pretty common one is tetracycline staining, which you can see in the picture here. It causes a very gray type of coloring to the teeth, and it just can't be removed because it's coming from within that tooth. So then we have exogenous stains, which originate outside the tooth and are caused by environmental agents. They can be further subdivided into extrinsic and intrinsic stains. So extrinsic appear on the exterior of the tooth and can be removed, and examples include foods, drinks, tobacco stains, things like wine, red wines, pasta sauces, smoking, tobacco. They can all cause different stains on your teeth. Teas, coffees, things like that. And then intrinsic stains are stains incorporated into the structure of the tooth and cannot be removed. So some examples include some more deeper tobacco stains like very prolonged use, and even dental amalgam stains, that silver coloring coming from a very old amalgam filling. It kind of corrodes and tarnishes inside of the tooth structure and can actually stain the tooth itself. So next we'll talk about kind of different tools that we need to do a coronal polishing. So a prophy angle, which you can see in both of these pictures, one's plastic, one's metal here, it attaches to a slow speed handpiece, not the high speed, but the slow speed. They can be disposable, where they are one-time use, and then that entire head is thrown away, such as the blue example here to the side. That whole piece will come off and be thrown away in between every patient. They can also be reusable though, where the prophy angle, the metal part in this other picture here, is sterilized every use, but then just a new prophy cup is attached to the tip, sort of like a burr, where we can remove and replace burrs. Very similar. So we can sterilize the handpiece, just replace the cup itself. And you do want to hold the handpiece and prophy angle in a pen grasp, with the handle resting in the U-shaped area of the hand between the thumb and index finger. So almost similar to a pencil, you're going to hold the handpiece while doing a coronal polish. Always use a fulcrum for stability, similar to using a handpiece. Next, let's talk about polishing agents. So selecting the appropriate polishing agent is super critical when doing a coronal polish. It's recommended that we use polishing pastes that are high polish but low abrasion. So you're going to get that nice clean feeling without damaging the tooth structure at all. They do come in various grits, from extra coarse, coarse, medium, fine, and even extra fine. So extra coarse, the particles are going to be more abrasive. Extra fine, very small particles that will do very little damage. Again, coarser the agent, the greater the abrasion. And the goal is to always use an abrasive agent that produces the least amount of abrasion while still removing the stains of the tooth. So we want to do as little bit of damage as we can, but still having patients feel like they are getting a good cleaning. Factors that influence the rate of abrasion, the amount of abrasive agent used. So obviously the more product you're using, it's going to do a little more damage to the tooth. It's going to cause a little bit more abrasion. The amount of pressure that's applied to the polishing cup. So the lighter the pressure, the less abrasion. If you have a heavy hand though, you're going to cause a little bit more damage. Also the rotation of the speed of the polishing cup. So the slower the speed, the less abrasion. The higher rate of the speed, the more abrasion. Polishing tips. So when we scoop up the product into our polishing cup, we typically want to use 1 cupful of polishing agent for about 1 to 2 teeth. So that doesn't refer to the actual polishing product itself that comes in a little cup, but it refers to the rubber cup that's on the end of the handpiece. So if you get a full scoop of that polishing paste into the prophy cup, you can do a few teeth with that. So you don't want to take 1 scoop and do an entire quadrant or the entire maxillary or mandibular. You want to do a few teeth at a time. If the cup becomes empty, it does generate more heat, which can, of course, cause some issues. Polishing each tooth for about 3 to 5 seconds is best. The more time you're spending on each tooth, it's going to cause more issues, more abrasion is going to be a result. Use moderate intermittent pressure to permit heat dissipation. So heavy pressure equals more heat, lighter pressure equals less heat. So there will be some areas that may have some heavy staining. Try to polish them in spurts. So maybe do one pass over that area, go to another tooth, and then come back and do the rest of the polishing, just so you're not applying too much heat to that tooth. And also use the lowest possible handpiece speed, where you can move the cup, but it's not stalling because you're going so slow. A whine or a whistle in the handpiece indicates that you are just going too fast. The cup is rotating too fast, and it's probably causing a little bit of damage. Now, there is a proper protocol for performing a coronal polish. So first you want to begin with the distal surface of the most posterior tooth and work forwards towards the anterior. So start in the back, move to the front. The stroke should occur from the gingival third towards the incisal third of the tooth. So we're starting near the gum line and then working our way up to the incisal edge. Establish a finger rest and place the cup almost in contact with the tooth, so have that fulcrum ready. Apply intermittent strokes with 1 to 2 seconds in between each stroke. This allows that heat to dissipate a little bit before continuing to polish the tooth. Each tooth should be completed in approximately 3 to 5 seconds, and you should use a patting, wiping motion, and an overlapping stroke to ensure that no spots are missed. Next, we'll talk about coronal polishing armamentarium. What do we need when doing a coronal polish? So first, we need the patient's dental record. We need to go over their health history, when's the last time that they've had a polish done. All of that is important. We'll then need the basic setup, so a mirror and explorer at the minimum. A patient bib and clip as well, because it does sometimes get a little messy. The saliva ejector and air water syringe tip. That way we can give the patient a rinse, either between polishes or at the very end. Eyewear for the patient and operator as well, just to keep our eyes safe. A low-speed handpiece with a prophy angle, or they do also make cordless prophy handpieces where the rheostat isn't even used. It essentially works with how hard you press down on the handpiece itself. There is options available as for what kind of tip you use. There's a rubber prophy cup or even bristle brushes that you can use. Next, you'll want to pick out your prophy paste or polishing agent to make sure you're selecting the correct grit type for the patient that you have. A 2x2 gauze is helpful as well. You can also use a disclosing agent where the patient is going to essentially put a little tablet in their mouth, and it will stain any areas that are heavy with plaque or any other debris, so you can ensure that you're getting all the areas needed while you're polishing. And then dental floss is great as well, so that you can floss after you're done. So coronal polishing procedure steps. First, we want to ensure that the dentist has authorized that a coronal polish is indicated for the patient, and also ensure that the patient is not allergic to anything you're being about to use. That includes the prophy paste or even the rubber in the prophy cup itself. Seat the patient comfortably, apply the bib and the protective eyewear on the patient. Next, you'll visually inspect the patient's mouth. Look for areas of staining, any areas of gingival recession that you may need to keep in mind, areas of a lot of plaque, things like that. A disclosing agent can be given at this time prior to the polishing to just show the patient areas of plaque, areas they need to work on when they're brushing. It also helps you visualize what areas you need to focus on a little bit more. Next, you can apply polishing agent to the inside of the rubber cup or just the tip of the bristle brush, whichever type of tip you use, by gently rotating the cup or brush over the paste. You'll then apply some polishing agent to the stained surfaces first before you even press the rheostat or spin the cup. This just allows some of that material to get on the teeth evenly. And then you'll want to use a fulcrum and apply light pressure to the teeth as the cup or bristle brush spins. Follow the gingival contour and into the interproximal surfaces. Stay away from any decalcified areas and use minimum pressure around areas of recession that the cementum is exposed or even the dentin is exposed. just to minimize the amount of abrasion that they receive. But light pressure, make sure you're using overlapping strokes as well to get all of the areas. You kind of have the patient use the saliva ejector as needed to remove any excess saliva or even to rinse out some of that polishing paste. A final rinse at the end is also a good idea. You can use dental floss to complete the procedure in order to remove any extra polishing agent that may be stuck between the teeth. Have the patient rinse thoroughly with water. And then also inspect for completeness just to ensure that all stains and excess polishing agent is removed. You can clean the patient's face with a damp piece of gauze that gets any excess saliva or polishing agent off of their face. And then a fluoride treatment may also be carried out at this time now that their teeth are clean. So how do we evaluate how well we polish their teeth? You can check for the following criteria. Teeth should be glossy and reflect light from the mirror uniformly. You don't want to have some areas are reflecting good and others aren't. That may mean that you have missed a spot. No evidence of trauma to the gingival margins or to any soft tissues in the mouth is apparent. So you weren't applying extra pressure to the gum tissues and causing damage there. And then if a disclosing agent was used prior to polishing, you shouldn't have any leftover disclosing agent. It should all be cleaned off from the polishing. So be sure to check out this video in the materials and resources section of this week's folder. Same for this video, it'll just go over some helpful tips and tricks when performing a coronal polish. Be sure to check it out in the materials and resources folder. Next, we'll talk about sealants. So sealants were developed to provide a physical barrier over occlusal fissures to help prevent plaque. They're typically placed as soon as the occlusal portion of the tooth erupts from the gum tissues. This helps to protect decay from forming in those deep pits and fissures of the teeth. Those areas can be especially difficult to clean for kids just because they don't have the proper dexterity or skills to just use a toothbrush appropriately. So a lot of the times kids are getting all of their decay in these deep grooves. Sealants help to prevent that. They can be placed in adults, but insurance usually isn't going to cover it for adults. They typically only cover children to have sealants up to age 18. So what are the retention rates for sealants? About 60 to 90% at 2 years, and then once you hit 5 or more years, it goes down a little bit to 60 to 70%. So sealants may need replaced at some point throughout the child's life, or they may fall out before they reach that adult status, and at that point they can choose to either have it replaced or maybe just they're old enough now to take better care of those pits and fissures. Patient education is very important as well when it comes to sealants. Patients should be made aware of the benefits of sealants and given the opportunity to have them placed. A lot of the times it's kids getting them placed, so who are we going to talk to these about these benefits? Their parents, not the children themselves necessarily. And children who are considered high risk for developing decay because they're either not exposed to fluoride, like in their water, or if they have a history of cavities in their baby teeth, or even if they have just newly erupted adult teeth with very deep grooves, they can all benefit from sealant placement. So what teeth should get sealants? Any tooth that is susceptible to decay and has deep grooves is a candidate for a dental sealant. Traditionally, first and second molars of adult teeth are what we typically seal. But other teeth can also be sealed, just not as commonly. So premolars, third molars, primary baby tooth molars, the linguals and maxillary molars and incisors, and also the buccal of mandibular molars are all areas that could be sealed. Let's talk about materials next. So most sealant material is made of the same material used for regular composite resins, a liquid resin monomer, which base is bis-GMA. So very similar to our flowable composites that we use. Most sealants do not contain filler particles though, unlike composites, which causes the sealant to be a little bit weaker than what we consider a composite filling. And glass ionomer sealants are not recommended anymore as a first choice sealant material, but they can be used as a preventative agent if moisture is thought to be compromised during the placement. So if you have an uncooperative kid who's not sitting still, saliva everywhere, you can technically use a glass ionomer sealant, but it's just not highly recommended. If you can use a regular like bis-GMA based sealant, that's always going to be your best case. Next, we'll discuss sealant curing methods. There's two primary methods that we use when curing sealants. So the first is polymerization or chemical cured. Chemical cured sealants were kind of what was first invented when sealants became a big thing. Not used too much anymore, but still a possibility. The advantages are that they do not require curing lights or protective eyewear. They cure on their own without the use of a special light. Disadvantages, the material sets rather quickly, so you have to be pretty quick when placing them, and the area must be kept completely dry the entire time that it takes that sealant to set. So if you have a very uncooperative child or someone who has a lot of saliva, this probably isn't the best method to use on them. And then the second method is photopolymerization, which means it's light cured with our curing light. It contains a photoinitiator, which is activated by light and therefore causes that material to harden and set. They can be clear colored, white colored, tinted. Some turn pink to white, just to let you know that it's fully cured. So many different options there. And opaque white sealants are the most common because they're easy to see during placement and easy to monitor at recall appointments. You can see if they've come out fairly easily, versus if you would use a clear sealant, it may not be very easy clinically to see if the sealant is still there when they come in for a future appointment. So a white colored one that is fully opaque, very easy to see if any spots are missing and need retouched up. Next, we'll talk about techniques used when placing sealants. Number one, plaque and debris must be removed from the pits and fissures first. So typically we're doing this with a pumice slurry in our prophy cups. We don't want to use that traditional prophy paste because it usually contains fluoride, and fluoride's not going to allow our bonding agent to properly bond to the tooth, as well as just a fluoride-free agent. So we're typically just using pumice. You can either use mix the pumice yourself, or they do make prophy cups that have pumice in them that is fluoride-free. So whatever you do, choose a fluoride-free product. Sealant should be placed before the placement of fluoride, which we just mentioned. The tooth should be conditioned with etch first, so typically we're using like about 37 to 50% acid etch, especially in those pits and fissures to allow them to receive the bonding agent a little better. Self-etching systems are not usually recommended for sealant application because we are bonding on uncut enamel, and because it's uncut enamel, it doesn't bond as well and requires that full acid etch that removes part of the smear layer involved to open those tubules up, versus the self-etching system. It's not going to open those tubules up, it's just going to kind of put a coating over top, and it could allow the sealant to come out a lot more easier than if you use a separate etching and bonding system. Ensure that all the etch is rinsed off. Make sure you're usually rinsing for about 20 to 30 seconds and using some air as well, just to ensure that there's no etchant remaining. Even if it's not visible, it still could be in those tubules. Tooth should then be thoroughly dried and appear kind of chalky and dull. The tooth must remain completely dry when placing the sealant. So if it receives any saliva contamination, you need to re-etch. And again, if it does get contaminated, usually you only have to re-etch for 10 seconds instead of the normal 15 to 30 seconds. So not as long. Next, we'll go over the procedural steps for placing a sealant. So number one, pumice the tooth with a prophy cup or a bristle brush. Rinse, dry, and isolate the tooth. You can use cotton rolls, dry angles, a combination, whatever you can do to make sure that that tooth is staying isolated the whole time. Etch pits and fissures and a little bit beyond as well, including the lingual grooves of maxillary teeth and the buccal pits of mandibular molars for approximately 15 to 30 seconds. You'll want to rinse adequately to remove all the etch and dry thoroughly until you see that chalky, frosted, dull appearance. Next, you want to place the sealant according to manufacturer's directions. This includes applying to all pits and fissures, including the lingual grooves of maxillary molars and the buccal pits of the mandibular molars. And that material should extend up cuspal inclines, but not cover the marginal ridges of the teeth. Avoid overfilling the tooth with the sealant material. This will mess up their bite then, and you'll have to take some away, which is, we want to try to keep things as easy as possible. So try to keep it to just a little bit beyond those pits and fissures. And then if there's any air bubbles present, before you cure, you can pop them with an explorer or even a micro brush as well, just to ensure that there's no voids or air bubbles. Next, you want to cure the material for 20 to 40 seconds. And always evaluate the sealant before removing isolation methods. That way, if you need to touch up a little spot, you don't have to start all over because spit contaminated the area. If you check before you even remove any cotton rolls or let the patient know that you're done, it's a lot easier to touch up any errors. If there are any errors or voids there, you can add a little bit more material and cure again. And then you also want to use a wet cotton roll to wipe off that thin surface film of the sealant that remains unpolymerized, which is the oxygen inhibited layer. That very top little portion is never going to cure because it's hitting the oxygen. So if you just remove that off with a wet piece of gauze or cotton roll, it'll remove that little layer. And then if needed, you're going to adjust occlusion. Always have the patient bite down on a piece of articulating paper and see if they are hitting prematurely on any of the areas that you just placed sealant on. If so, you can just do a quick polish there and check the occlusion again to ensure that that's cleared up. Why do sealants fail? So if a sealant fails, it usually does so pretty quickly, usually within the first 6 to 12 months of placement. It could be from poor isolation, so saliva became incorporated into the sealant, or it was never properly cleaned off before sealant placement. Poor patient cooperation. If it's a young child especially, they may not be sitting very still. They may try to close their mouth while you're working, move their tongue around, things like that. The tooth is only partially erupted, so it may still be partially closed off with gum tissues because it hasn't fully erupted from the gums. Residual etchant, so if you're not rinsing off the etchant well enough and it's leaving a small trace of it behind, it's not going to allow proper bonding. Inadequate curing as well, so if we're not curing for the recommended amount of time, it's just going to wash away with saliva easier. You're going to want to watch these videos that are in the materials and resources folder of this week's lesson. Same for this video, make sure you check it out in the materials and resources folder. Next, we'll talk about fluoride. So fluoride has been our primary weapon to prevent dental caries since about the 1950s, so a pretty good amount of time. It does slow the demineralization and enhances remineralization of tooth surfaces, which is very important in the fight against dental decay. It is a mineral that occurs naturally in food and water, and a supply of both systemic and topical fluoride must be available throughout a human being's life in order to achieve maximum cavity prevention benefits. So what are some benefits and implications of topical fluoride? So benefits include it helps remineralize the tooth enamel, it can help strengthen teeth, it reduces the risk of cavities, and can reverse early tooth decay as long as it's in that enamel still. It also prevents the growth of cavity-causing bacteria, which is great. Implications, though, it can be very hazardous at high doses. How common is it that we're ingesting that much of fluoride? Not very common, but there is a small possibility of that happening. And it can cause fluorosis, which is discoloration and mottling of the teeth if used in high doses again. So as long as you're using the proper amount of it, there really are no issues with the fluoride. If you're ingesting very high amounts of it, such as if it's in your water, you're using it in your toothpaste mouth rinse, and then also applying a topical fluoride every single day, you may start to see some issues from it, but that is very unlikely. Ways of receiving fluoride. So there are prescription strength fluorides that can be applied in the dental office. So that's where we're going to apply our our fluoride varnishes when we are seeing patients. There are also non-prescription strength fluorides that are sold over the counter for at-home use. So that can be in your toothpaste or mouth rinses. Fluoridated water. It's available bottled or sometimes even community water has fluoride in it. Some communities don't have it, some do, so you really have to check with your water source to see if your household does have it. And also certain foods such as canned shellfish, oatmeal, raisins, potatoes, black tea, or coffee can contain fluoride as well. So what is the difference between systemic and topical fluoride? Systemic fluoride is ingested in foods, beverages, or supplements that we take, so it's going inside of our body. The required amount of fluoride is absorbed through the intestine then into the bloodstream and then transported to whatever tissues it is needed. And then any excess fluoride in our body is excreted through the skin and the kidneys and in feces. Topical fluoride, on the other hand, is applied directly to the teeth through like fluoridated toothpaste or our topical fluoride varnish. It's not necessarily getting fully ingested into our body, it's more so sitting on the teeth for an extended period of time. How exactly does fluoride work? So before we even have any erupted teeth, fluoride is in there working hard. A fluid-filled sac surrounds a tooth before it erupts, and there is fluoride present in that sac, the fluid in that sac. So it helps to strengthen the enamel of the developing tooth and also makes it more resistant to acid before it is even erupted from our gums. And then after the tooth erupts, fluoride continues to enter the enamel and helps alter the structure of the enamel crystals. These fluoride-enriched crystals are less acid soluble than the original structure of the enamel, so it's going to help fight off carie-causing bacteria a little bit better and also help to remineralize any damaged parts of the enamel. So what are the procedural steps for fluoride application? One, you always want to follow manufacturer's instructions. I know I preach that a lot, but it's very true. Different products have different instructions, so make sure that you check whatever product you're using and see what the manufacturing company recommends. Typically, though, you're going to want to dry the teeth with gauze or air, just so that the teeth surfaces are nice and dry. They can better kind of soak up all of that fluoride and allow it to work a little bit better. Next, you want to mix the varnish until it reaches an even consistency. So some fluoride comes in a little packet with a little microbrush already in the packet. If that's the case, you want to just stir up the fluoride a little bit in the cup there before you place it on, so that way all of its components are mixed evenly. Some fluoride comes in a little small packet, so you can mix it inside the packet, and then I express it onto my glove and even mix a little bit more with the microbrush before I apply it onto the teeth. Next, you want to apply a thin layer of fluoride varnish to all surfaces of the teeth and cover post-op instructions with the patient according to the directions. And then as far as post-op instructions go, it's always important to follow the manufacturer's instructions because they can vary a little, but the basics are, I typically tell patients that they are going to feel like there's a sticky, fuzzy, like tacky, gross coating on their teeth, and they may not like that feeling. It may feel like their teeth are just not clean and they want to brush it off. But that is a normal feeling. They should not brush it off, and that fuzzy feeling is going to subside in a few hours. The more that they eat, talk, function, just have it on there, it will start to subside after a little while. Some varnishes do suggest that the patient only eat softer foods or avoid any hot foods or hot liquids for a few hours. So if that's the case, let them know that they should either eat soft foods or just drink cold liquids, usually about 4 to 6 hours afterwards. And then again, do not brush your teeth even if it has that fuzzy feeling. Even typically the night after or the night of the fluoride placement, you want to avoid brushing your teeth. So I usually instruct them to brush the next morning once they wake up. And of course, you can watch this video in the materials and resources folder this week. Thanks!